Good day everyone. Today we will be discussing about the drug named N-Acetyl Cysteine. N-Acetyl Cysteine comes under the pharmacological categories of mucolytics and antidotes. N-Acetyl Cysteine exerts its therapeutic effect in acetaminophen overdose through several mechanisms. Acetaminophen metabolism and therapeutic dosing primarily occurs through glucuronidation and sulfation, with less than 5% being oxidized by CYP450 isoform to produce a toxic metabolite called N-acetylp-benzoquinone imine, which is the precursor to cellular injury. Glutathione in the liver can normally detoxify these minuscule quantities of NAC and prevent tissue damage. In acetaminophen overdose, glucuronidation and sulfation pathways are saturated, and the CYP450 pathway has more significance, producing toxic metabolites that deplete the glutathione reserves, leading to their accumulation and subsequent tissue injury by binding to cellular macromolecules. N-acetyl cysteine repletes glutathione reserves by providing cysteine, an essential precursor in glutathione production. N-acetyl cysteine itself also binds to toxic metabolites and scavenges free radicals. N-acetyl cysteine also increases oxygen delivery to tissues, increases mitochondrial ATP production, and alters the microvascular tone to increase blood flow and oxygen delivery to the liver and other vital organs. In COPD, cystic fibrosis, and other lung conditions, nebulized N-acetyl cysteine has mucolytic, anti-inflammatory, and antioxidant properties. Studies are ongoing to understand therapeutic efficacy, ideal dose ranges, and the most effective mode of drug delivery for these indications. N-acetyl cysteine is the mainstay of therapy for acetaminophen toxicity. N-acetyl cysteine has FDA approval for the treatment of potentially hepatotoxic doses of acetaminophen, and it is almost 100% effective if given within 8 hours post-ingestion. N-acetyl cysteine is also FDA approved for use in conditions with abnormal, viscid, or inspissated mucus secretions such as pneumonia, bronchitis, tracheobronchitis, cystic fibrosis, tracheostomy patients, postoperative pulmonary complications, post-traumatic chest conditions and before diagnostic bronchoscopy to help with mucus plugging. Off-label indications include acute hepatic failure, prevention of contrast-induced nephropathy, and topical treatment of keratoconjunctivitis sicca. N-acetyl cysteine may also have therapeutic applications in chronic valproate hepatotoxicity and acute pennyroyal or clove oil ingestion-induced hepatotoxicity. The American Association for the Study of Liver Diseases guidelines suggest that N-acetyl cysteine might also have potential benefits in cases of drug-induced liver injury unrelated to acetaminophen. Oral N-acetyl cysteine may cause nausea, vomiting, diarrhea, flatus, and gastroesophageal reflux. For N-acetyl cysteine can cause rate-related anaphylactoid reactions in up to 18% of patients, which is not an issue with the oral route. Most anaphylactoid reactions are mild or moderate, with severe reactions like bronchospasm and hypotension rare at 1%. Interestingly, anaphylactoid reactions occur more commonly with lower acetaminophen levels than with higher acetaminophen levels. One possible explanation is that acetaminophen decreases the histamine release from mast cells and mononuclear cells proportionate to the dose ingested. Bronchospasm more commonly occurs in patients with pre-existing reactive airway diseases, like asthma. Bronchodilating agents are effective in treating these patients. Nitroglycerin interacts moderately with N-acetyl cysteine, as their co-administration may result in hypotension and nitroglycerin-induced headache. Carbamazepine, when co-administered with N-acetyl cysteine, can result in a lower than desired blood concentration of carbamazepine. In patients with a tendency to develop fluid overload such as cardiomyopathy or congestive heart failure, the quantity of diluent fluid used in 4N-acetyl cysteine must be appropriately titrated to prevent fluid overload. Monitor for acute flushing and erythema of the skin when given 4. Usually, they are associated with administration of the loading dose and resolve spontaneously after continued infusion. Monitor for serious anaphylactoid reactions for 4 administration. An infusion may be stopped until the treatment of anaphylactoid symptoms has been initiated. N-acetyl cysteine infusion should be used cautiously in patients with a history of bronchospasm or asthma. The total volume must be adjusted for patients requiring fluid restriction and those less than 40 kilograms. During 4N-acetyl cysteine administration, patients require monitoring for manifestations of an anaphylactoid reaction, In the case of acetaminophen toxicity, plasma or serum acetaminophen concentration post-loading dose and after the last maintenance dose is suggested to evaluate efficacy. As the pharmacokinetics of patients with severe hepatic impairment are altered, monitoring through hepatic function tests such as ALT, AST, bilirubin, and prothrombin time is necessary. Evaluation of renal function should be performed by monitoring serum creatinine, blood urea nitrogen, blood glucose, and electrolytes before initiating the whole course of therapy. Patients with a medical history of asthma or bronchospasm administration of N-Acetyl Cysteine require monitoring. Thank you. Kindly comment for further queries and doubts.